This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 770, recorded on June 17th, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Now, 770 is not a plane, is it, Daniel, right?
But I like that number. It's a nice, easy to remember, 770. We'll have to see, do I end up hitting 777? Boy, would that be lucky.
Yeah, that's the big one. I flew one of those to Singapore once. It's an amazing plane. It's really quiet.
I miss that. I miss traveling. I miss getting to all these places. I miss my friends in Panama, in Uganda.
Yeah, you miss your cows in Uganda, right?
Yes, I do. I'm worried they're not going to recognize me, and the next time I go in there, instead of getting like nuzzled by Bryony, I might get a horn or something. So
yeah, they won't remember you. Yeah, you got to go back. Maybe next year you'll be able to go, right?
I'm hoping. I'm going to be heading to Ghana in January, and I hope to be able to figure out a time to get to Uganda. But I have to say, my friend Titus, who's in Blantyre, Malawi, is actually saying things are not so great down there. They're starting to see what for them is a third surge. So tough times.
Not a lot of vaccination in Africa, right?
No, and actually that's what I'm hearing is they're having issues with they were allocated certain amounts and now they're getting less than even they were allocated, which are already small amounts to begin with. So it's tough times for my friends there.
Well, maybe we can give them our Novavax stockpile, right?
I hope so, actually. Yeah, I think that would be great. All right. Well, we've got a lot to cover today. I remember a few weeks ago, my dad was asking me, really, is there something new every week about COVID? And actually, I was on the local news channel on Monday morning with Elizabeth Hashigan. And actually, she told me at the end, she said she has never gotten more questions during an appearance than she got during the time I was on. So people have lots of questions about COVID. So let's start answering them. So let me start with our quotation. The worst thing we can do right now would be to mistake progress for victory. And that is our own Andy Slavitt. Andy Slavitt is actually known as the Fixer. I say our own because he's was one of our executives at Optum for a while out in Minnesota. And he was really instrumental, I think, in a very successful vaccine rollout. But he's actually now going to be a competing podcaster, Vincent. He's In the Bubble is his podcast. I listen to it regularly, and I will shout out. It's great, good stuff. All right, let me give a little bit of an update. Case rates and deaths are down across the country, getting lower here in New York. We've gotten over 70% vaccination coverage in New York, not quite as good as 80% up in Vermont, but still some hot spots. I think everyone is aware of this. And, at the risk of controversial, this tends to correspond with low vaccination rates. Maybe people think there's causality there. And worldwide, again, it really seems like the same situation. We're seeing numbers come down, but again, certain areas, and again, seems to be corresponding with areas with low access to vaccinations or low vaccine uptake. We're also seeing, another variant, the Delta variant. And this has been sort of interesting. One of the things that was suggested, and we'll hit a little bit on this, is that maybe this is a little bit harder to distinguish from other viral infections. Maybe there's a slight difference in clinical presentation. And we'll hit, it's actually the Scots in the UK. It's actually an app, the Zoe app in the UK, where when they're looking at symptom reporting, it looks like they're seeing more sore throats, more runny noses, less of the classic presentation. Now, I do a call every week with our urgent care docs. I'm sure some of them are listening. And among our adult populations, I don't think there's enough of the Delta variant out there that they've really noticed much difference. But last night I was on a call with Jay Berger, the head of our large pediatric group. And they're actually still seeing COVID cases every week. And he was actually saying, in that population, it's always presented with more of a sore throat, runny nose. So I don't know if it's so much a variant presenting clinically differently, or if it's just that people are now seeing it in a younger age group, which I'll say for the whole pandemic has always presented in a way really difficult to distinguish. And this is a question I remember like a year plus ago. It was actually Dr. Mensch, one of the medical directors at a hospital, and he was going through asking all kinds of questions about, well, how can we tell whether or not it's COVID versus something else? And I was like, you know what, Dr. Mensch, there is one test. It's called the PCR. And I think we're still there. So a lot of attention back to the early days of the pandemic, which I hope will position us better for the next zoonotic pandemic. And a lot of this is when did COVID-19 get into our country? So one of the publications, Antibodies to SARS-CoV-2 in All of Us research program participants, January 2nd through March 18, 2020. And this really builds on other work, including David Ho's serology surveys here in New York City, Washington Heights, Columbia. And these authors used serum obtained as part of the All of Us research program. This is an observational cohort study that, beginning in May 2018, enrolled diverse adults greater than 18 years of age in the United States from study site locations in all 50 states, with a goal of enrolling at least 1 million participants. So relying on serology testing, these authors reported that they found positive serology for SARS-CoV-2 as early as January 7th from Illinois, January 8th from Massachusetts, February 3rd from Wisconsin, February 15th from Pennsylvania, March 6th in Mississippi. And this is really consistent with a paper published back in the fall, Serology Testing of U.S. Blood Donations to Identify Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2, Reactive Antibodies, December 2019 through January 2020 in CID. And that actually, they had reported in that paper on SARS-CoV-2 reactive antibodies, saying they had detected them in 106 blood donations from California, Oregon, and Washington as early as 13 through 16 December 2019. And among donations occurring in early January in Connecticut, Iowa, Massachusetts, Michigan, Rhode Island, and Wisconsin. So I think this really goes back, right? I mean, this keeps coming up. They keep, talking about the identification of this in, Wuhan, China. And I hate to say, when they identified it in Wuhan, China in December, it was already here in our country, it looks like. So maybe we should take off our hat and say, thank you for picking up that something was going on, because we had it here in our country already. There actually was a Frontline special, PBS Frontline special, The Virus, What Went Wrong. And you can actually hear the story there. And this was made about a year ago, about how here we were in the United States seeing lots of patients with unexplained respiratory infections. We were seeing them in the community. We were seeing people dying in the hospitals. We had suspicions that something was going on. We were desperate to be able to sort this out, but we had no access to testing and weren't really able to confirm it. And tells the story here about how it's actually that Westchester patient that we finally were able to get a test result on February 29th, but he had been sick for a while. And we sort of later realized, boy, there were thousands of people that already had COVID-19 here in New York by the time we identified that gentleman in the end of February. Children and COVID. Children are at low risk, but they are not at no risk. And I don't know if people remember my old mantra, let us open the schools. If we need to close the bars, that's fine. So more on children and COVID. And this will be a little bit of an overlap from, 769 TWiV, which covered a little bit new information on the article. This is the article I'll be talking about, Incidence of Multisystem Inflammatory Syndrome in Children Among U.S. Persons Infected with SARS-CoV-2. This paper was published in JAMA Network Open, but there's really nice discussion on 769, not only just about this issue, but maybe a little deeper dive into maybe some ideas about gut-tight junctions and super antigens. But this article was really a look at the incidence of multi-system inflammatory syndrome in children, so MIS-C, in those under 21, should they get COVID. So they looked at data from Connecticut, Georgia, Massachusetts, Michigan, New Jersey, New York. They excluded New York City, Pennsylvania, and the data analysis was conducted from August to December 2020. And they actually reported an incidence of 31.6 persons per 100,000 SARS-CoV-2 infections in persons younger than 21. So this is about 1 in every 3,000 children who got COVID ended up with MIS-C. They did point out that the MIS-C incidence among Black persons, Hispanics, and Latino persons was approximately 9 times higher than among Caucasians, about 3 times higher among Asian Pacific Islanders. And so I'll suggest this is perhaps a lower risk, right? Because as we've discussed before, many cases in children do go undiagnosed. I just want to add that caveat. But we're starting to get I think, information here because, parents are trying to decide, should I just wait and let my child get COVID, versus the risk that might be associated with vaccination. So just putting that in context. Another paper, and this is going to help us with myocarditis discussions. This paper was prevalence of clinical and subclinical myocarditis in competitive athletes with recent SARS-CoV-2 infection results from the Big Ten COVID-19 cardiac registry, right? So this is our university athletes. We'd heard a little bit about this in preprint, but now this was published in JAMA Cardiology. And I think this can give us some perspective as concerns are raised about potential risks of heart inflammation or myocarditis post-vaccination. So the authors here report on a cohort study of 1,597 U.S. competitive collegiate athletes undergoing comprehensive cardiovascular testing and the prevalence of clinical myocarditis based on a symptom screening strategy was 0.31%. If they went ahead and screened with magnetic resonance imaging, it actually was as high as 2.3%. So this gives us a 1 in 300 chance of symptomatic myocarditis and about a 1 in 43 chance with sensitive screening should individual in this age group get COVID. So, as I say, this is perhaps a lower risk because, right, as we discussed right above, some cases go undiagnosed, so got to have that caveat. But I think this gives us perspective to concerns about the post-vaccination myocarditis risk, of which there are a few hundred cases under investigation. They tend to be mild, limited to a few days, versus what we see with the virus here, which has actually resulted in long-term impacts. We actually know a lot of athletes who actually were not able to actually compete because of the severity of a post-COVID infection myocarditis. So I think this is just more information for people to have in the mix when they're making decisions about vaccination. I was talking to my wife a little bit about the sort of discouraging fact that we're still seeing thousands of COVID cases every day. Most experts are predicting an increase come fall and winter. So you compare the potential risks associated with vaccination versus the real risks of getting COVID and the complications that we know about from that. But then balancing the risk and perspectives, what about the impact of the pandemic on mental health issues here in our adolescents? The article Emergency Department Visits for Suspected Suicide Attempts Among Persons Aged 12 to 25 Years Before and During the COVID-19 Pandemic, United States, January 2019 through May 2021. Now, this came out as an early release in the CDC MMWR, and the authors reported that in May 2020, during the COVID-19 pandemic, ED visits for suspected suicide attempts began to increase among adolescents aged 12 to 17, especially girls. And during February 21 to March 20, 2021, suspected suicide attempt ED visits were 50.6% higher among girls aged 12 to 17 than during the same period in 2019 prior to the pandemic. And I really think that if you look at figure 1 in this paper, it's very sobering, as one can see the weekly ER visits for female adolescents with suspected suicide attempts rising to over 1,000 per week. Now, the authors acknowledge several limitations. First, my first tendency is feel guilty that we caused this through physical distancing, including a lack of connectedness to schools, teachers, and peers, barriers to mental health treatment, increases in substance use and anxiety about family health and economic problems, which I think we all experienced. These are all risk factors for suicide. But we also have seen that the average ED visits for mental health concerns and suspected child abuse, neglect, risk factors for suicide attempts also increased in 2020. The authors, acknowledge that there could be alternative explanations here. But I've talked a bit with our urgent care physicians, and I think a lot of people have suggested that both this was very evident that there was a significant impact on mental health, that we didn't really need a publication like this. But others have actually suggested that there's even a bigger problem than we see here. So many visits to urgent care centers with cutting and other results of mental health challenges in our children struggling in school, parents frustrated and struggling with often very unhealthy parent-child and even parent-parent dynamics. So I was talking to my friend, Dr. Lucy McBride, sort of I think a bright light in this spot over the last year, just about how we really we need to do better. All right, pre-exposure period transmission. This was an interesting correspondence in The Lancet. SARS-CoV-2 Delta VOC in Scotland, demographics, risk of hospital admission, and vaccine effectiveness. Now, the authors use the word strain a bunch, so I'm going to replace that with the word variant. They report that on May 19th, 2021, the Delta variant of concern, formerly known as the Indian VOC or B1.617.2, became the dominant variant of SARS-CoV-2 in Scotland. I wonder how long, this would be like Prince, how long we have to, formerly known as throw in there. But the Alpha variant of concern had been dominant previously. I'm not going to give the AKA there, but this was rapidly replaced. A few interesting findings. So the Delta variant of concern in Scotland was found mainly in younger, more affluent groups. Interesting. I'm sure about the affluent part of that. Risk of COVID-19 hospital admission was approximately doubled in those with the Delta VOC when compared to the Alpha VOC. Both the Oxford, AstraZeneca, and the Pfizer-BioNTech COVID-19 vaccines were effective in reducing the risk of SARS-CoV-2 infection and COVID-19 hospitalization in people with the Delta VOC. So interesting publication there. All right, testing. Never miss an opportunity to test. This has become a challenging arena and really dealing with false positives, particularly on asymptomatic screening. So we've done this a few times, and I'm hoping that clear minds prevail. We get some clinical judgment allowed in terms of interpretation for our camp, school, and summer programs. So this is the concept of a positive predictive value and a negative predictive value. So the big message here is that when we get to a prevalence below 1%, that's where we are in most parts of the country, the majority of those positive tests are going to be false positives. We're forced in a lot of jurisdictions to still count any test as positive and follow sort of the rigmarole that follows from that. But we're hoping that, if someone is low risk, it's screening, you do a secondary confirmatory test that is negative. We'd love to have just a little bit of flexibility here to use some clinical judgment. But that is actually what I'm spending a lot of time with, meetings, going through, because there will be, you do hundreds of tests, you're going to get some positives, and the majority of those are going to be false positives. All right, active vaccination. Never miss an opportunity to vaccinate. Vaccines are how this pandemic ends. We heard from Novavax. This was covered on 769. The Novavax COVID-19 vaccine demonstrated 90% overall efficacy and 100% protection against moderate and severe disease in Prevent-19 phase 3 trial, right? Press release, so we don't have a full peer-reviewed preprint. But this is a recombinant nanoparticle protein-based COVID-19 vaccine that uses technology similar to the current shingles vaccine, Shingrix, pertussis, hepatitis B. This, in all honesty, people ask for, I want a traditional vaccine. In many ways, this is. So a little bit about the trial, the catchy name, right? Vincent did a good job of that. PREVENT stands for the pre-fusion protein subunit vaccine efficacy Novavax trial. This was a 2-to-1 randomized placebo-controlled observer-blinded study to evaluate the safety, efficacy, immunogenicity of this adjuvanted vaccine in 29,960 participants, 18 years of age and older, in 119 locations in the United States and Mexico, compared with placebo. 77 cases were observed, 63 in placebo, 14 in the vaccine group. So remember, this is 2 to 1. So you can sort of think of that 63 versus 7, or 126 versus 14, just to understand why the numbers are what they are. All cases observed in the vaccine group were mild. 10 moderate cases and 4 severe cases were observed, all in the placebo group, yielding a vaccine efficacy of 100% against moderate or severe disease. It's all very positive. Safety data was actually quite positive. And at least what I have heard is that the people that got the vaccine versus the people that did not get the vaccine, the degree of reactogenicity was minor enough that people had a tough time telling. So that will be quite nice if we have a vaccine with a little less reactogenicity. I think it'll be nice. I'm sure we'll have people wondering if they didn't get placebo in the future. They're getting used to a nice big reaction. Now, they did give us a little bit of information about variants, but I'm going to sort of leave it there. Another potential great tool for us to have that looks like it's also efficacious against the variants. All right, pregnant women and vaccination. Always a hot topic. CDC MMWR, again, with COVID-19 vaccination coverage among pregnant women during pregnancy. But that was sort of redundant, but okay. 8 integrated healthcare organizations, U.S., December 14, 2020 through May 8, 2021. And so data from the Vaccine Safety Data Link, so VSD, a collaboration between CDC and multiple integrated health systems, was analyzed to assess those that received greater than 1 dose or first or second dose of Pfizer-BioNTech or Moderna or single dose of J&J, and basically went through and the high point I'm going to say, they looked at a total of 135,968 pregnant women, and they identified no safety concerns. All right. We got more real world data on our monoclonals. And I like to say the first week, right, the viral symptom phase, the time for monitoring and monoclonals, and also where you get your test is ideally where you get your monoclonals. So real world data on bamlanivimab, the article, early monoclonal antibody administration can reduce both hospitalizations and mortality in high-risk outpatients with COVID-19. This was published in CID out of UC San Diego at La Jolla. The authors performed a retrospective review of medical records of patients referred to their clinic from 11/1/2020 to 2/28/21 and identified 617 patients at high risk who were offered monoclonal antibodies. 175 received them, 442 did not. The monoclonal antibody group was older, more men, more comorbidities, higher risk score. But despite that, there was a significant reduction in hospitalizations in the monoclonal antibody group versus control, 1.7% versus 24%. No COVID-19 related deaths in the monoclonal antibody group. There were 12 among the controls, which really breaks your heart, right? All these people were offered monoclonals. A number refused. A dozen of those died as a consequence of that decision. So I think it's really important for clinicians and patients to realize that particularly in those unvaccinated, monoclonals are a really powerful tool. But now things get a little bit complicated. This is a twist. And I think everyone who is used to everything I've said about monoclonals and how timing really matters, this is a little nuanced because now we're going to talk about a subset of hospitalized patients that may actually benefit, that do benefit from monoclonal. So we heard about data from the UK recovery trial. And I have to say, I was very excited about this. This is stopping people in the hall at the hospital. We got to talk about this. And this was, we got a press release from Regeneron, REGEN-COV. So this is the casirivimab and the imdevimab phase 3 recovery trial meets primary outcome, improving survival in hospitalized COVID-19 patients lacking an immune response to SARS-CoV-2. So the primary outcome was all-cause mortality in hospitalized seronegative patients. They received Regeneron-COV 8,000 milligrams versus just usual state of care, and this reduced all-cause mortality by 20% in seronegative patients compared to usual care alone. So 24% of the folks in the Regen COVID arm died versus 30% in the usual care by day 28. So this is really an important point, right? This is not saying, oh, wow, now it works in hospitalized patients. This is saying that if you give it to people who end up in the hospital who missed that first window, remember that first window, nobody died. Here, you still had 24% of the patients dying, but that was a 20% reduction. When you combine the larger seropositive group, there was no longer a significant impact. So this is already something where they are looking for expansion of the EUA. So if a patient shows up in the hospital, maybe their oxygen saturation is 92, 93, someone might think we need to admit them for remdesivir or something else. If they are seronegative, it looks like there still is a benefit in that subgroup to getting Regeneron cocktail therapy. The median hospital stay was 4 days shorter, 13 versus 17 in those that got the cocktail when we're looking at their seronegative group. I'll read they had that quoted summary, and this is the takeaway. The recovery trial has shown that in patients who had not made their own antibodies against SARS-CoV-2 treated with Regeneron-CoV antibodies dramatically reduced their risk of dying or being on a ventilator, and also shortened how many days they remained in the hospital. So I think that this is practice changing. But I still will say, if you can get it in that first week before they end up in the hospital, we are not seeing people dying in our trials, where here a quarter of these people died. But that was less than the people who did not receive therapy. Long COVID, post-COVID, I feel like we're still in a bit of limbo here. Still very limited in what we can offer patients. But we did this week get some guidance from the CDC. It's both honest, accurate, and a start. So let's wrap up today before we get to emails with some of the key points from the CDC interim guidance on post-acute sequelae of COVID. So key points. The term post-COVID conditions is an umbrella term for the wide range of physical and mental health consequences experienced by some patients that are present 4 or more weeks after SARS-CoV-2 infection, including by patients who had initial mild or asymptomatic acute infection. 2, based on current information, many post-COVID conditions can be managed by primary care providers with the incorporation of patient-centered approaches to optimize the quality of life and function in affected patients, right? So they're saying here a lot of these people can be managed by their primary care physicians. They do not need to be referred to specialty centers. The third, and I think this is really important, objective laboratory or imaging findings should not be used as the only measure or assessment of a patient's well-being. Lack of laboratory or imaging abnormalities does not invalidate the existence, severity, or importance of a patient's symptoms or conditions. I have to admit that particularly one hits close to home. I lately had a woman who was severely cognitively impaired, and the disability decision was basically, there's no objective lab or imaging abnormalities, so we're going to drop her claim and not continue to cover her. So I think it's really important that this is recognized. Healthcare professionals and patients are encouraged to set achievable goals through shared decision-making and to approach treatment by focusing on specific symptoms. So for example, if they have a headache or conditions such as dysautonomia, a comprehensive management plan focusing on improving physical, mental, and social well-being may be helpful for some patients. But then just the honesty at the end. Understanding of post-COVID conditions remains incomplete, and guidance for healthcare professionals will likely change over time as evidence evolves. And I'm going to say, as we understand better what is going on and how to help these individuals. We do actually have quite a bit of a challenge. I'm actually in a meeting almost every day trying to look at how to address this issue. But we do have challenges because in part it's hard to identify these individuals. We don't necessarily have a diagnosis code, so we can't look through claims and say, oh, how many people are suffering from long COVID. But I was in a meeting earlier this week hearing that there may be a new code, this U09.9 might become active in October, and that might allow a physician to identify this is a person who not just has a new diagnosis after COVID, but may have this post-acute sequelae of COVID syndrome that we're all growing familiar with, the brain fog, the fatigue, the other disabilities. I will finish there. But then again, thank everyone for your continued support. I've noticed lately a lot of people are going to Patreon and just sort of setting up for a monthly contribution, which thank you so much. We're continuing through May, June, and July. Donations made to Parasites Without Borders will be doubled up to a total contribution of $40,000 to Foundation International Medical Relief of Children. This is really a tremendous organization that's out there helping people in the world struggling. We really want to support them because we are not safe until everyone is safe.
Time for some email questions for Daniel. If you have one, you can send it to daniel@microbe.tv. Mark writes, wondering if you have seen any cases of PAM as a vascular stage sequela of SARS-CoV-2 infection in your practice.
PAM. So who knows what PAM is? Paracentral acute middle maculopathy. So this is actually an issue where you have ischemia to part of the eye. So you have retinal capillary ischemia. And a lot of those patients, this is well described, unfortunately, post-COVID. We know that COVID is not just a pulmonary disease. It's a vascular disease. There's clotting abnormalities. And so these patients are actually being managed by our ophthalmologists at this point. But yeah, this is a quite a challenge, and I think just more evidence of that COVID is a disease that affects the entire body. So yeah, we actually recently, it was actually Tuesday night, we have a COVID recovery clinic here. We set up here at ProHealth, like a lot of institutions have set them up. And a lot of what we do at that intake is connect patients with specialists that are committed to helping them. So when a person is seen with this presentation, we connect them with one of our ophthalmologists.
Chaim writes, with most indoor spaces rapidly moving to masks optional, what do I need to do to best keep my 7-year-old safe? Is his mask enough to protect him, at least for short exposures? What about longer, like synagogue services? Should we just be keeping him away from all public indoor places other than school for the rest of the year until he can get vaccinated?
So this is an excellent question. And I know a lot of people have, you hit on several points in your question. And one of them, I think a big issue is a lot of people have not been going to church, synagogue, mosque over the last year, or I guess Wiccan outdoor circles. I don't want to leave out the pagans, sorry there. But there is a risk that has to do with how much virus is in your community. And so what we're seeing in a lot of communities is an incredibly low prevalence incidence. And so let's take like my immediate area where our test positivity rate is less than 0.5%. These are places where you can start looking around high vaccination rates, low incidence of virus. You can start doing a risk calculation. There are other parts of the country where I'm going to give really the opposite advice. Low vaccination, still seeing lots of infection. So you're going to have to balance that risk here. The mask really protects us when other people wear them. There is some protection you get from wearing it yourself. I sort of think of it as the 80-20 rule. You're getting about 20% of that by you wearing it. You get about 80% if everyone else is wearing them. The other is really, as I brought up, vaccination, if you're in a place where people are vaccinated. And again, it's going to be a risk sort of threshold, risk tolerance. I actually went to the gym yesterday and I took off my mask for the first time. It felt really uncomfortable. If I had young children, I think this is really important. Parents need to know sort of the risks, need to make decisions they're comfortable with. There's a few months left. We think we're going to be in September having the ability to vaccinate younger individuals. Parents should have that as an option should they choose it come September. So you got to sort of weigh that.
Alina writes, question regarding a B-cell depleted patient with multiple sclerosis in her 40s, last infusion of rituximab, February 2021, first dose of Pfizer, April, second dose 3 weeks later. In May, some B-cells detectable, less than 0.5%. Because of a former medication, there's a T-cell deficiency. T-cell responses are going to be tested anyway, as well as lymphopenia. She was tested for antibodies 3 weeks after the second vaccine dose. There were none at all detectable. Another round of shots is going to be administered July, hopefully in time before the next round of rituximab will be needed. Surgery because of a precancerous disease is at the moment being postponed until after vaccination, but has to happen in fall this year at the latest. Question, What's to be done if the second round of vaccines does not build an immune response? Could monoclonals be a temporary solution for her for prevention of COVID in high-risk settings like during hospitalization where masking is not possible? Here in Germany, monoclonals are not licensed for preventive use, so there happens to be the practical problem of how to get hold of them, even as the patient is willing to pay for all medication import transportation. Any ideas are highly appreciated.
So this is a great question, and we brought up several times before. There are millions of patients here in the United States. There are millions and millions of individuals throughout the world in very similar situations where they've received the vaccine. They don't have detectable antibodies. It's hard to do the T cell test outside of a research setting, to be honest, right? The adaptive T detect is the algorithm for analysis is set up to detect natural infection, not great for telling us, are you immune? Do you have a T cell shield, so to speak? The double vaccination, people are definitely doing, sort of hear that kind of in there. A lot of people are giving even at least a third dose, right? This is all sort of outside. It's being actively studied at the moment. COVID's different, I got to say. If a person, I was just going over needle stick injuries yesterday with our frontline physicians, and we tend to say, oh boy, if you were vaccinated and if you have negative serology, then people actually get immunoglobulin to protect them after acute. So there are some studies. Actually, Regeneron published a preventative study. It makes sense. A lot of the monoclonal antibody manufacturers are looking at that. Different monoclonal antibodies have different half-lives, so it makes sense. There is some data to support that. A lot of it here in the U.S. I'll be able to share when that is part of the EUA for another indication. Once something is licensed, as our listeners may know, a physician could choose to use it off-label. Germany is going to be a particular different challenge, but that is sort of what we think is on the horizon for individuals that can't make their own antibodies. Potentially, we can give them those antibodies.
And finally, from Jonathan, I'm an internal medicine hospitalist who's getting revenge against COVID by administering vaccines. I've been heartened to see our clinics here in San Diego fill up with young adolescents for Pfizer vaccine. However, I'm getting questions from parents about myocarditis in this population after the vaccine. It appears that the risk may be increased. It appears most cases are mild. However, it often helps to discuss these kinds of things in context. What is the underlying rate of myocarditis in this population? What is the relative risk of COVID infection versus myocarditis? What are long-term effects or serious outcome percentages in kids who get this inflammatory state? I can see a parent supportive of vaccination say, prevalence of virus where we live now is very low, so why risk having my kid get this vaccine-related condition?
So this is an excellent question. Hopefully we've hit on some of the topics today. And I always frame this for parents that it's really a decision about vaccination versus getting COVID, right? Things are a little quiet here. We expect to be a little quiet over the summer. We are expecting to see increases in the fall and the winter. So as my wife says, boy, with what we're doing, if you don't get vaccinated, it's just a question of when you or your child get COVID. So that's how I try to weigh it. I say, well, if your child gets COVID, I think we put the numbers out there. There's about a 1 in 46 chance that they're going to end up with myocarditis from the infection itself based upon the athlete study. A lot of those cases will be asymptomatic, so you won't even know that. We know that some of those cases have been severe enough that these athletes have been unable to perform, unable to participate in sports. So we know about the longer term outeffects of natural infection. But what about vaccination? We've done millions of vaccinations in our country. There are a few hundred cases of myocarditis under investigation. The vast majority of those have really lasted for a day or two. They've gotten better with over-the-counter medications. They've resolved. The children have done well. I understand the argument, oh my gosh, but who knows long-term? Well, I think we know enough long-term. If you only had a very mild case that resolved in 48 hours or less, there's really minimal expectation that that's going to do serious harm to the heart. But boy, if you let your child go ahead and get infected with COVID, myocarditis is just one of the risks that you would be concerned about.
That's COVID-19 Clinical Update number 67 with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you so much. And everyone be safe.